Hi, everybody. I appreciate the opportunity and being invited to participate. I see a number of my patients here. So hello, everybody, and nice to meet everybody who I haven't met before. So immunotherapy, it's the hottest and sexiest topic that we have in oncology nowadays. So everybody wants to know about immunotherapy. So, as far as just some disclosures, many of the slides that I used for this were provided from the cancer support community. I am employed by the Torrance Memorial Health Foundation. As stated, I do a lot of research and I'm active in clinical trials with Cedars-Sinai and UCLA, but I do not have any direct financial relationships with those entities, and I do not have any payments from industry. So as far as the program overview of what we'll talk about tonight, we'll talk about immunotherapy, the generalized what is immunotherapy, who is it right for, what you should know about immunotherapy and potential clinical trials, types of immunotherapy, possible side effects, quality of life ramifications, and the future of immunotherapy. And there will be room at the end for question and answers. So as far as the treatment of cancer and our treatment arsenal that we have, historically, we've always had surgery, right? Breast cancer, colon cancer, lung cancer. Surgery has been a mainstay and will remain a mainstay of treatment for many of our cancers, most of our cancers, except for our hematologic cancers. Chemotherapy is the idea of using chemical warfare. Some might call it poisoning the cancer cells, but we're actually using it as toxins to kill the cancer cells. We have radiation. Many of you have heard of endocrine therapies, especially our breast cancer survivors, where we use hormonal therapies or the opposite, lack of hormones to starve cancers, especially breast cancers and prostate cancers, of their food, which is hormones. You may have heard of targeted therapies, the idea of using a rifle or a sniper attack to attack the cellular mechanisms by which cancer cells divide. And what we're going to talk about tonight are immunotherapies, or empowering the own immune system to attack cancer. So what is immunotherapy? So it's a broad category of types of cancer treatment that uses the body's natural defenses, your immune system, to identify, attack, and kill cancer cells. So the immune system is designed to attack a cell it sees as unhealthy or abnormal. So the immune system is supposed to screen all the cells in the body to identify abnormal or bad cells to kill them. Immuno-oncology is the field of cancer research to understand how the immune system interacts with cancers and trying to use that to attack cancer cells. So the immune system is your body's defense system against disease, microbes like viruses, bacteria, fungus, etc. And viruses, bacteria, or any abnormal cells often carry tags or badges on the surface of the cells on the membrane that allow the immune system to recognize them as being normal cells or abnormal cells. So those tags on the surface of the cells are called antigens. So immunotherapy treatments can fight cancer by many different mechanisms, but some of it may be by boosting the immune system so it can better recognize cancer cells as being cancerous and then attack them, marking cancer cells so the immune system can again recognize them and destroy them, and helping the immune system find cancer cells and deliver treatment such as chemotherapy, radiation, even tagged to some of these medicines, or even using T cells, which are the killer cells of the immune system, to kill cancer cells. So the evolution of immunotherapy has been years in the making. And I took this slide from online from a website. And this actually doesn't quite show how long it's taking for us to understand immunotherapy. So the first reports that I could find of the idea of immunotherapy actually goes back to about 2,800 years ago. So back in the Egyptian times. In the Egyptian times, there was an Egyptian physician named Imhotep who actually used reports of actually treating cancers. These probably were breast cancers or sarcomas or cancers of the soft tissue. where they would intentionally lance and introduce infections into these cells or into these tumors. And there were reports of when you would cause an infection of that cancer, that there were reports of it actually shrinking. Now, obviously, in the days before antibiotics, that was probably not a good idea to introduce infections, okay? But even up until 100, 200 years ago, the same idea kept on persisting of being able to try to use infections to try to somehow stimulate the immune system to attack tumors. In the modern era, in the 1890s, was a guy named Coley who developed this Coley concoction of basically dead bacteria that he would sell and introduce into people that he argued would be a way to try to improve the immune system to attack cancer. Never good data for it, but that was kind of the first start of it in the modern era. 1970s and 80s was kind of the basics understanding of the science behind it. In 1976, actually, we still use this today, was the use of BCG in bladder cancer, where we actually introduced kind of a killed bacteria entity and wash bladders. And we still do this. We wash bladders with BCG to let the immune system get stimulated to get into the bladder and attack bladder tumors. Okay, still done today. And then starting in the 1990s, a lot of tonight, we're going to talk about checkpoint inhibitors. That was this discovery of checkpoint inhibitors and the mechanism. But it wasn't until 2011, 20 years later, that was the first approval for checkpoint inhibitors. So it's taken a long time. Now, when I first graduated medical school in 2002, we had largely given up on immunotherapy. There were certain immunotherapies we used, but the idea of vaccines and other therapies had always failed. And so when I graduated and went to fellowship to understand hematology oncology, really this was on the back burner. It wasn't until really the last 15 years where we actually started making much better progress. So how is immunotherapy given? It's usually given through an IV, through a venous infusion. Of course, different immunotherapies are given differently on different schedules, and sometimes we give them in combination with different therapies. So sometimes we use multiple immunotherapies together. Sometimes we use it with chemotherapy. It really depends on the diagnosis and the status of that disease. So as far as about other terms to understand, again, we talked about the immune system. When we talk about T cells as opposed to B cells, T cells are the killer cells of the lymphocytes. So these are the soldiers which actually attack cancer cells. That's opposed to B cells, which make antibodies. So you'll hear us doctors describe B cells versus T cells. Antibodies are secreted by B cells. A tumor antigen is like something on the surface of tumor cells that we can use for the immune system to try to recognize that as being a cancer cell. A biomarker is any molecule in the body that we doctors use to measure. Sometimes we follow biomarkers for different kind of cancers. So key things to know, it's important that anyone receiving immunotherapy, this is not chemotherapy, but it can still cause toxicity that we'll talk about. Immunotherapy, of course, doesn't work for everybody. It's only indicated for certain diseases, although probably the majority of our common diseases we now use immunotherapy for certain situations. Side effects can occur, mainly autoimmune toxicity that we'll talk about, and there's still a lot we don't understand about the immune system and immunotherapy. So questions that we're continuing to try to answer is, why do immunotherapy treatments work so well in some people and not in others? How could they be combined with other treatments? When is the best time to use immunotherapy, and how long, if it works, how long do we use it for? And then what are the long-term side effects? So is immunotherapy right for you? So who's eligible? Most people who receive immunotherapy today have very advanced cancer. Okay, it is starting to move up now more so to earlier stage cancers, but historically it was first approved in stage 4 cancers, or some cancers that are stage 3. Okay, so it's usually in the advanced stage. Historically, it was approved only in the palliative setting, where we're trying to control disease and prolong life, but not to cure it. Now, some immunotherapies are now moving into the curative setting for certain cancers. okay? Some people cannot receive immunotherapy. So we're mainly concerned about people who have autoimmune disease already, people with lupus, people with rheumatoid arthritis, people with inflammatory bowel disease. So what does it cost? So these treatments are extremely expensive. Okay. Again, when we use it, it's in the setting of a clinical trial where it's paid for by the clinical trial, or in the setting of standard of care treatment. So it is covered by the insurance. However, every insurance has different copays. So it's very important to evaluate cost up front. If you were started on immunotherapy or any of our modern treatments nowadays, everyone needs to understand that there are patient assistance programs that can pay for most of these treatments. And so usually that does not become an issue. So anytime we give any treatment, whether it be immunotherapy or not, I always believe, and we believe, that clinical trials are always preferred if we can place someone on a clinical trial, not just to try to help you, but to try to help other people in the future. Okay, so we always are evaluating for clinical trials. So as far as types of immunotherapy, so we're not going to go into too much detailed specifics, because otherwise we'll be here for many hours. But there are many different types of immunotherapies. Okay, so the most common immunotherapies that are talked about now are called checkpoint inhibitors. Okay, there are also other monoclonal antibodies, and that usually antibodies we usually talk about historically as targeted therapies. And nowadays there's a lot of overlap between targeted therapies and immunotherapies. Most immunotherapies are a type of targeted therapy. There's also cellular therapies, which are namely the T cells, where we try to get the killer cells to attack cancer. There's cytokine treatments, there's vaccines, and there's oncolytic viruses. So these are all different ways of trying to get the immune system to attack cancer. So checkpoint inhibitors. So like I said, if you see a TV commercial about cancer treatments nowadays, most of them are going to be an advertisement about checkpoint inhibitors. Okay. So how do checkpoint inhibitors work? So the immune system has safeguards in place to prevent it from attacking healthy cells. So your immune system is supposed to try to recognize bad cells as being bad and kill them, but at the same time, recognize normal cells as being normal and leave them alone. So there are safeguards in place for the immune cells not to attack you. So the idea of people with lupus or rheumatoid arthritis, those safeguards have failed and your immune system is attacking you naturally, okay? So those safeguards that are in place are called checkpoints. So they're meant to slow down or stop the immune system. The immune checkpoints, when stimulated, okay, can dampen the immune response, okay? When depressed, can increase the immune response. So some cancers have learned how to hide from the immune system. Part of the reason why cancer can become cancer is by hiding from the immune system, okay, by cloaking itself from the immune system. So what they have done is actually produced on the surface of their cells something called PD-L1, okay? So on this diagram here, on this cartoon, so the tumor cell in purple and the T cell in blue. So there's a marker on the surface of the tumor cell called PD-L1. Not important to remember the name, but that stands for Programmed Cell Death Ligand 1. So imagine that being a badge that you could show a police officer that says, let me go through, don't worry about me, just I'm a good guy, okay? On the surface of the T cell is PD-1. Imagine that being the badge reader that takes that badge and says, okay, you're good, keep on going, okay? So that's one of the mechanisms that tumor cells have found how to be able to be felt to be a good guy by the T cell. So what happens with these checkpoint inhibitors is that we created antibodies against either PD-1 or PD-L1. So either we're blocking and getting rid of the badges that the cancer cells are using, or we created antibodies against the badge readers on the T cells, right? So if you get rid of the badge or you get rid of the badge reader, Well, that mechanism is gone. Okay. Therefore, the cancer cell cannot use the badge to get back past the T cells, and then the T cells can then hopefully actually see that cancer cell and hopefully recognize it as being as a bad cell and then kill it. Okay. That's how checkpoint inhibitors work. So most checkpoint inhibitors today are one of two kinds, either using that mechanism, the PD-1 or PD-L1. So that's like the Keytrudas or pembrolizumabs of the world. Nivolumab, otherwise known as Opdivo, atezolizumab, that's the PD-1 and PD-L1 blockers. There's also CTLA4 antibodies, which actually have like a similar mechanism for the badges, but what's called CTLA4. And if you've ever heard of Yervoy or ipilimumab, that's those. Not all cancers are treated with these drugs, but these are the most common immunotherapies that we use nowadays. So these include, again, Tecentriq or atezolizumab, avelumab, durvalumab, cemiplimab, nivolumab, pembrolizumab. Don't ask me where they come up with these names. They're crazy names, but I think as doctors just use them to make us sound smarter. As far as where they're used, so it's amazing how many cancers we use these in. This may not even be the complete list. They were adding cancers to this pretty frequently nowadays. So melanoma, lung cancer, Hodgkin's disease, Merkel cell cancer, kidney cancer, liver cancer, head and neck cancer, colorectal cancer, bladder cancer, cervical cancer, breast cancer, and skin cancer. Okay. So initially, we just have used these in each individual cancer. If it shows activity, then it gets approved, and stepwise by stepwise, cancer by cancer by cancer. One of these, Keytruda, otherwise known as pembrolizumab, actually is now approved for what we call is tissue agnostic. If any cancer has certain criteria listed there, it can be used in any cancer. Okay, so if any cancer, even if it's not one of the FDA approved ones, but if any cancer has what's called microsatellite instability, being high, meaning a tumor mutational burden, how many mutations we see in that cancer, greater than 10 mutations per megabase, that's called microsatellite high or instability. If there's deficient mismatch repair proteins, then these all qualify for Keytruda. So even if someone has some random tumor that's like, something we barely ever see and not well studied, if it has any of these features, that does allow us to use immunotherapy that's approved by the FDA. So I'm not going to go at length of these, but this is just a list of avelumab used in Merkel cell cancer and bladder cancer. Keytruda has a huge list of cancers. This is the most common immunotherapy that we use. Opdivo, again, similarly, I think it was the second immunotherapy that was approved, and similarly with a very long list of cancer treatments. Atezolizumab, Tecentriq, durvalumab. Okay, this is Libtayo. This was very interesting because this was actually approved for skin cancer first, skin squamous cell carcinoma. If you live long enough here in the South Bay and live a long enough life, most of us will get squamous cell cancer of the skin. This actually shows a 50% response rate for people who can have surgery or radiation, which is pretty dang high of trying to get the immune system to control these skin cancers. Yervoy, ipilimumab, this is again not the PD-1 or PD-L1. This is a CTLA4 antibody, again used for melanoma, and can be used. Well, like I said, some of our immunotherapies we use in combination with other immunotherapies. So this can be also used in colorectal cancer and other cancers. So checkpoint inhibitors are now sometimes combined with each other. But whenever we start combining immunotherapies together, we do increase the risk of autoimmune toxicity, increasing the immune system too much, and thereby causing basically a lupus-like reaction where the immune system starts to attack you instead of the cancer. So you will sometimes see other monoclonal antibodies as well. These are just one type of monoclonal antibodies. There are other monoclonal antibodies that we use. Not all monoclonal antibodies are immunotherapies. And again, sometimes we are more appropriately referred to other kind of therapies as targeted therapies. So just a case example of one of my patients, no patient identifiers on this, but she's a patient of mine who I met in 2015 at the age of 48. So she had a stage 3 triple negative breast cancer, not driven by hormones. She had very advanced disease, stage 3C. She received very aggressive chemotherapy, followed by surgery. She had 14 lymph nodes removed. 13 of the lymph nodes still had cancer in them. We gave her adjuvant radiation. Adjuvant just means post-surgery. So adjuvant radiation. She got further chemotherapy. She recurred in 2016 with disease up and down her left arm and in the soft tissue of her left chest. At that time was deemed to be stage 4, not considered curable. She got further radiation, further chemotherapy, but then continued to progress and had really difficult pain. So we put her on a trial that we had back in 2017. And this was a phase 2 trial with atezolizumab, one of the PD-L1 antibodies, along with this oral targeted therapy that was trying to increase the immune system as well. So within 4 months, she was in remission. All of her disease in the arm and in the chest wall had disappeared. That study, interestingly enough, was a negative study. So about 2 years ago, she was the last person on that clinical trial. That trial closed because that oral drug did not show benefit in addition to the IV drug. So she was in remission. So we took her off the oral drug because the trial closed, but it's now been 5 years and 3 months since he started the intravenous checkpoint inhibitor, and she's still been in remission. I often ask my colleagues, and I talk about her, because I wonder, for someone in remission for 5 years and 3 months, she was not supposed to ever be cured. But I wonder, could she have been cured by this treatment to be in remission for so long? I have left her on treatment because I'm afraid to change anything. Don't fix what ain't broke. But I wonder if she's possibly one of these miracle stories. So this is her. So I know these CT scans are hard to tell. This is a cross-section where you're looking at a cross-section of the abdomen, but really where those measurement markers are in the top left picture, that's a cross-section of her arm. And that's actually a measurement of the tumor that was right up against her forearm. So those two bones, the white things, that's her radius and her ulna. And that mass that's next to it, that's the cancer. So that cancer was bigger than the bones themselves, and it was up and down the arm. So by 4 months later, that was gone, that picture on the bottom right. And just a different way of looking at that same mass in an up and down picture. The top left was before her treatment. The bottom right was 4 months later, and her disease has never come back. So that's the power of immunotherapy. Now, the poster child for the start of immunotherapy was lung cancer. Okay. For years and years and years, our treatment of lung cancer has all been about surgery, chemotherapy, radiation. And lung cancer, unfortunately, is a very high-risk disease. Okay. Unfortunately, most people with lung cancer are diagnosed at an advanced stage. If someone has lung cancer, their chance of being cured if they have stage 3 disease is about 15%. Okay. So unfortunately, most of our patients with lung cancer will eventually have metastatic disease and have their disease come back. Okay. In the old days, if their disease come back, it was all about chemo and literally life expectancy. When I first came into practice, we would celebrate the fact that we were able to, without chemotherapy, people used to die from lung cancer, metastatic lung cancer, within about 6 months. When I first came out into practice, we were celebrating because we, on average, were getting people to about 9 months. And then came out some of these targeted therapies where we, on average, could get someone to 12 months. And that was big news back then. Well, that's boring news now. Nowadays is the molecular era of treatment, and lung cancer is the poster child, not just for immunotherapy, but for targeted therapies. So if you go along this algorithm, so this is the NCCN. The NCCN is the National Comprehensive Cancer Network that developed standard of care guidelines since about 1998. So no longer, we used to say you could go see 5 different doctors and get 5 different opinions on what's best. This is now the standard of care based on best data for the vast majority of cancers. So for someone with advanced lung cancer, we go down the algorithm. So as you go down to the right, you see the first step that we do for lung cancer for advanced or metastatic disease is we do molecular testing, looking for all different mutations, because that can allow us to use targeted therapies, which are sometimes even pills to treat cancer. And we also do what's called PD-L1 testing. Again, that is the marker on the surface of the cancer cell. That's the target for certain checkpoint inhibitors. So these are all the things we test for now for lung cancer, okay? So all these have treatment ramifications that if someone shows a certain mutation or has a certain PD-L1 level, that can hopefully allow someone to use other treatments beyond chemotherapy. So this is now the treatment for stage 4 non-small cell lung cancer. So we do the molecular testing, we do PD-L1 testing. In the old days, it was all about chemo. Nowadays, about 25% of people will have the option of using targeted therapy. Now, these are pills, which can often allow people to live well, have a response to their treatment for multiple years of just taking a pill. Down below is the option of pembrolizumab. If that tumor has the target for the checkpoint inhibitors, the PD-L1, if it has 50% of the cells or more having that little badge that they're trying to use to escape the immune system, then we use just immunotherapy. We don't use chemotherapy, we just use immunotherapy. So that's about 30% of patients. So that still leaves about 45% of people who don't have that, who get chemotherapy, and we still give immunotherapy, but chemotherapy and immunotherapy. So the majority of patients nowadays with advanced lung cancer are being treated with non-chemotherapy options, okay? And that's what's allowed people nowadays to live oftentimes for multiple years when they used to die within 6 to 12 months. So as far as other kind of monoclonal antibodies, there are immunotherapies now in blood cancer. Historically, the immunotherapies were focused on solid tumors. Now we have immunotherapies for blood cancers. For acute lymphoblastic leukemia, that's what my wife had when she was a child. I remember reading this article. I think it was probably around 2013 to 15. But the CAR T cell treatment, which we'll talk about in a little bit, for ALL. This was ALL for adults is really a death sentence. For kids, thankfully, the majority are cured. But this was a population of patients with ALL, adults who had really exhausted all standard treatment options. And years ago in Miami, of all places, I think it was University of Miami, not the best known academic center, but they had a clinical trial of like 13 patients with ALL. And they gave this treatment to, which we'll get to, using fighter T cells. And I think like 12 out of the 13 went into remission, and the majority of them were in remission years later and presumably cured of their disease. So that's ALL, okay? With targeted therapies, AML with targeted therapies, CLL with targeted therapies. Hodgkin's disease has targeted therapies. Non-Hodgkin's lymphoma has targeted therapies, immunotherapies. Multiple myeloma. Nowadays, if there's any myeloma patients here in the waiting in the room, Darzalex or daratumumab is a treatment we're giving all the time now, which is a targeted immunotherapy. So it's the majority of our cancers now have other treatments beyond just chemotherapy. So this is what I was just talking about. So cellular therapy. And I think this is the most exciting thing to me as far as trying to cure cancers which historically have not been curable. The checkpoint inhibitors, the CTLA-4 antibodies, I mean, certain cancers like kidney cancer, certain cancers like melanomas, those are the ones where those kind of treatments can actually be curative. The other cancers that I'm talking about, lung cancer, breast cancer, colon cancer, those cancers, unfortunately, I do not expect with the therapies we've been talking about so far to be curative. It's still trying to control the disease, prolong someone's life, maintain quality of life, but not to cure patients. Cellular therapy is different. The idea of cellular therapy is taking out your T cells. So imagine your T cells being your army. Your T cells are the army of your immune system that actually do the fighting, okay, and attack bacteria, attack viruses, and can attack cancer. So CAR T cells, chimeric antigen receptor T cell. The idea of this is to take out your army, put them through special ops training to fight a certain enemy, a specific enemy, and then put that army back into you to attack the cancer. So it's a living immune attack army. So that's very different than the antibodies we've been talking about. The antibodies are not alive. These are antibodies which are very active, but they don't persist in you. If you don't keep on getting it, they don't keep on fighting, okay? So CAR T cells are living antibodies. So this is a little cartoon of how it works. So CAR T cells, and right now this is only done in academic centers. So we send it up to Cedars or UCLA or wherever, but these are collected from the blood with what's called pheresis. It's similar to giving like a blood transfusion, but much more volume. So we take out the T cells from a specific person's bloodstream. That gets sent to a laboratory, okay, where these T cells are trained how to attack a specific antigen, a marker on the surface of cancer cells. It takes weeks. So this is not something you just go in and get. It takes weeks for that laboratory to grow millions of these T cells. And then they inject them back into that patient. And those are, again, their own cells. They're just special forces now. And those are living, breathing T cells, which can further keep on dividing and to kill the cancer if it works. So these T cells, okay, this is the FDA approval so far. So Kymriah, Yescarta, Tecartus, Breyanzi, Abecma, Carvykti, these are all active T cells which are currently approved by the FDA and standard of care. Now, as far as the list of targeted diseases, so non-Hodgkin's lymphoma, originally aggressive lymphoma is called diffuse large B-cell lymphoma that relapsed refractory. More recently, follicular lymphoma, the most common slow-growing lymphoma. Now we have the T-cell, CAR T-cell treatment, which is actually curative. So historically, those kind of diseases, if that disease came back, that was the only way we could historically cure them is with an allogeneic bone marrow or stem cell transplant, right? Bone marrow transplants. Now we call them stem cell transplants. But those can be quite toxic and cause long-term healthcare risks or even death from the transplant itself. These T cells, okay, these are also curative for those diseases. And most academic centers now are actually preferring these T cells for these diseases over a transplant, although they can be used as backup. So if someone gets T cells, they could use transplant as a backup and vice versa. Now, for multiple myeloma, the T cells that we use, they're only now approved for the fourth line setting. So people would have had to have 4 lines of treatment before being qualified for CAR T cell treatment. But for multiple myeloma, unfortunately, it's not curative. Okay. This is still palliative. Now, maybe at some point we'll get to a way to find something that's good enough to be curative, but at this point, it's not curative. Now, the reason why I mentioned that this is, in my mind, the most exciting type of immunotherapy is because these T cell therapies are being studied in just about every cancer now, as far as trying to find a marker on the surface of these other cancers that allows us to eradicate those cancers with T cells, right? So if you can get a living army to attack that cancer, we just need to pinpoint a marker on that cell that allows us to kill it. But the challenge with solid tumors right? As opposed to these liquid tumors, leukemia, lymphoma, myeloma, is that a lot of the markers on the surface of solid cancers are also the same markers found on your normal tissue, on your normal body. So it is a challenge because if you give a living army special ops trained to attack something that's not just on the cancer cells, but on you, it's very hard to turn off, right? This is not an antibody which wears off after a few weeks. These are living T cells. So we have to be very careful not to attack the normal body. So those targets, it's slow and steady about trying to make sure we find the right target when we try to investigate for solid tumors. There are other kind of treatments called cytokines. So I did mention earlier about melanoma and immunotherapy, okay? And also beyond melanoma, kidney cancer. So melanoma and kidney cancer have historically, even 20 years ago, we called those as the immunogenic cancers. Immunogenic meaning immune causing. The idea of that is that even 20, 30, 40 years ago, there were miracle stories and true case reports. These weren't just anecdotal reports of someone being cured of a miracle treatment. These were validated true stories of like 1 in a million cases of melanoma and kidney cancer, where patients could have disease all over their body, even without any treatment at all. There were miracle stories and proven cases of people who their cancers disappeared. And we figured out why. It's because those cancers, are the immunogenic cancers where the immune system, after a certain load, of cancer, would recognize those cancers as being cancerous and then attack it. What we're trying to do nowadays with pushing the immune system. So we've always called those immunogenic cancers. So some of those cytokines we used to use something called high-dose interleukin-2. That's actually a cytokine in our own bodies. If you get an infection and you have fevers and chills and shaking, chills and rigors, some of that is because of the release of interleukins and something called interleukin-2 that's released by the infection that makes all those symptoms. And part of the reason why people get those symptoms is because those cytokines are building up in order for your immune system to get triggered to attack the infection. So even 20 or 30 years ago, we used basically the same chemical that's released when you have an infection, and we called it high dose. So we extrapolated it, made it in a lab, and injected it into people. So we mimicked basically the worst infection you could ever imagine in your life. We mimicked sepsis. We would actually inject this, cause sepsis symptoms, where people would have to be basically in the ICU, shaking like crazy. Their blood pressure is going down just like an infection. Their kidneys and their liver are getting affected. But that could actually cure a minority, but about 7 to 8% of people with kidney cancer and melanoma by using these kind of just inflammatory chemicals. Now, because we have such better treatments now, we don't like to do that because you could kill someone doing that treatment. Okay, I did it. Unfortunately, I took care of plenty of patients at UCLA when I was there at City of Hope. Now, we don't use these anymore because they're just way too toxic. Okay. Other treatments that you might hear about are the vaccines. Now, the vaccines is why when I graduated medical school, why we were so pessimistic about the field of immunotherapy, because everybody was trying to do vaccines. Well, unfortunately, vaccines have been so far a pretty big failure, okay? They're still trying to study vaccines, and the idea of a vaccine is to, again, give some sort of antigen, you inject it and see if the immune system can recognize it and then recognize cancer cells. But the only FDA-approved vaccine is something called Provenge. That's used for prostate cancer. With Provenge, oftentimes with any treatment, we talk about, well, what's the chance of it working? What's the response rate, right? The answer to Provenge is 0. So when we studied this, when it was first approved around, I think it was 2013, it had 0 response rate. But the average person who got it lived instead of 21 months, lived 25 months. That was before we had a lot of advances in prostate cancer. So I have actually never prescribed Provenge before. I kind of describe it as you're paying for a Ferrari and you're getting a 1970s Pinto. Okay, so I personally don't like it. Now, that being said, it is an option still for people today, but I think we just have so many better treatments now that I don't push Provenge at all. Now, hopefully we'll have better vaccines in the future, but it has been rather disappointing. Now, it's what's interesting is that with all the advances we've made, remember I said BCG started to be studied and used in the 1970s? This is actually kind of a dead bacterial concoction, almost like that Coley's concoction from the 1700s. But literally, it's a dead bacteria concoction of liquid that we put through a scope through the bladder for superficial bladder cancers. And it's only for superficial because this liquid doesn't get deep into the bladder muscle. It's only superficial. But we wash the bladder with it, and it causes an inflammatory reaction. It doesn't directly kill cancer, but it causes an inflammatory reaction. That inflammatory reaction means immune cells come to the surface of the bladder and thereby can kill bladder cancer. So this is one of the main treatments we use for superficial early bladder cancer, and it's used all the time. So oncolytic viruses, again, there's only one. This is, again, not anything too interesting because there's only one approved currently in per the FDA for melanoma, where you actually inject this directly into the melanoma. If someone had a melanoma on their skin, you could inject it directly into it. And these are viruses that are trying to kill viruses that are used to try to kill off some of the cancer cells. So you can see some responses locally, like in the skin with it. Again, we have so many better treatments now systemically to kill cancer cells, including on the skin. This is really not used too much anymore. Still being studied. Okay, possible side effects. So when immunotherapy was first approved, we often were using it mainly for lung cancer, and patients were ending up in the ER sometimes, thankfully not often, but sometimes, let's say with severe diarrhea. If you're on immunotherapy and you have severe diarrhea, that is not normal, okay? It can happen, but chemotherapy commonly causes diarrhea. If you have chemotherapy, drink your Gatorade, lay low and stay off the chemotherapy for a while, and then it should recover. But immunotherapy is because chemotherapy is because of toxic therapy, right? You're giving a poison which can be toxic to the gut. If you get side effects from immunotherapy, it is because of the immune system getting too high, right? And so if you have severe diarrhea or nausea, vomiting from immunotherapy, it's because the immunotherapy has caused the immune system to start to attack the intestine. The treatment for that is recognition that that's not normal. And if someone has nausea, vomiting, diarrhea, or anything like that, that's not expected. And if someone gets that, we need to treat with steroids, okay? So steroids, just like we give steroids for asthma, we give steroids for people with bronchitis. Why? Because it knocks down the inflammatory response. It knocks down the immune system. We also give steroids for lupus. But if someone has side effects from immunotherapy, the first treatment, which tends to work very well, is steroids like prednisone, okay? So I always tell patients, if you're on immunotherapy and anything weird is going on that's not otherwise explained, you need to let us know, because if it was bad enough, you need to be on steroids. Now, the most common side effect we see is rashes. Rashes are actually quite common, usually pretty mild. And if it's just a mild rash, we sometimes just watch it, or sometimes we use topical steroids like hydrocortisone cream. But if it became severe, then again, we use oral steroids, systemic steroids. I've never had a patient die from immunotherapy before. It's been reported. I've never seen it before. I don't think anyone in our practice has ever died of immunotherapy before. But again, any treatment could theoretically cause severe, even life-threatening side effects, okay? So what are the side effects? Some flu-like symptoms. Usually that's just the day of or day after the treatment. That's not from autoimmune side effects. That's just because any antibody treatment can cause that. Some fatigue. Rashes, again, are the most common thing we see. Some aches. Infection is usually not expected. Any treatment could potentially cause infection, but again, we're not suppressing the immune system. If anything, we sometimes elevate the immune system. So we usually do not expect infections with this unless we're combining it with chemotherapy. If we're combining it with chemotherapy, then certainly chemotherapy can increase the risk for infections. Less common side effects, again, colitis. If you have nausea, vomiting, or diarrhea, you need to let us know right away. Not uncommonly, we see thyroid disease, so it can cause hypothyroidism. That's probably the number one long-term risk with immunotherapies. It can burn out your thyroid, but that's a simple fix. People just have to take Synthroid or thyroid medication. It can affect anywhere in the body, though. It can affect the livers, the kidneys, the heart. I've never seen the heart before. But it literally, just like lupus, it can affect anything in the body, even the lung with what we call pneumonitis, okay? So actions you can take. Again, what we tell people is if you ever have anything weird going on that's not otherwise explained, you let us know, okay? These side effects are usually very easy to treat, easy to knock down. These antibodies don't persist for the checkpoint inhibitors very long. Usually in your system for weeks, if not a month or two. And it's usually as soon as we start steroids, those side effects start to go away. So for its quality of life, we expect usually a normal quality of life on most immunotherapies. So if someone gets a little bit of a rash or something like that, it's usually maybe a little bothersome, but most people can continue to live a completely normal life, normal quality of life, okay? So unless you get some of those more severe autoimmune toxicities, this is not chemotherapy. This is not a toxin, okay? Most of our patients have little to no side effects whatsoever. The most bothersome thing is coming in every 2 to 6 weeks, depending on the regimen, to have to come in and get the infusion. Beyond that, most people live a pretty normal life. So what is the future? The future of immunotherapy is everything I just talked about, but it's getting more and more tailored to figure out, well, why does this immunotherapy work for this person? Why did it work for my patient who may be cured of her breast cancer when she wasn't supposed to be cured? And why did that, in her disease, that trial actually was a negative trial, but it worked in her. So as we move on into the future is trying to identify what immunotherapies are best for which disease and why do some patients respond so well and some don't. So in the past 10 years, we've had an explosion of immunotherapy, okay? And the next 10 years from now, it's going to be astronomical as far as the number of treatments that we're going to have available. The challenge will be fine-tuning as far as what treatments are best for what indication and for what patient. And always an issue with talking about these new treatments coming out is it's great that we have such great treatments, but I always get concerned about the cost of all these treatments. Okay? The reason why the United States is, and so some of the reasons why we're in such financial difficulties is because I think we spend over 20% of our GDP, our gross domestic product, on healthcare. Okay. And largely it's because, number one, a lot of us are living so long now, which is great, but a lot of it is because of these therapies where these drug companies, I don't want to stand on my soapbox, but they charge so much money for these treatments. And unfortunately, in the US, there's laws in place where Congress has to approve any drug that's approved by the FDA. Medicare has to cover that drug, and the drug companies actually set the cost of these drugs after they have already been approved. So it's like saying you're going to go buy a car and we're going to tell you how much that is after you've actually agreed to sign on the dotted line and pay for it, right? So it's kind of a silly situation. In Europe, it's not like that. In Europe and England, their equivalent of Medicare, you have to submit the cost of that drug before their equivalent of Medicare will approve it. That seems to be much more rational. Okay. But unfortunately, nowadays with politics, they don't call it rational, they call it rationing, right? They say, okay, we can't limit the treatment, but that is a lot of the controversy nowadays in our world as far as the government goes in politics. So I do agree with trying to have the government nowadays. There's some laws in place saying that the government can start to try to negotiate with these drug companies. But again, that's a whole separate issue that I have with these treatments. As far as resources go, these are all resources that any patient can get on the web. So like at the very bottom, every 99% of our cancers that we deal with have algorithms in the National Comprehensive Cancer Network. That's the standard of care, the best treatment we know about. Patients have access to it. This is free. I look at it almost every day. So any patient can go on for their own treatment or ask their doctor to discuss that with them. But this is what we use as the standard of care now. Of course, the American Cancer Society, Cancer Care, CancerNet, the cancer support community, of course, the National Cancer Institute. If someone's interested in clinical trials, there's cancer.gov/clinical trials. So almost every clinical trial in the United States is registered with the National Cancer Institute. You can go online, enter in your cancer, what stage you have, any other extra information. And you just say, well, how many miles away from my home do I want to know what clinical trials are available? And it will just come up with a list. It's a very simple thing. The Torrance Memorial has developed a community resource list. This is just the first page. The full document has 13 pages of resources. Okay. So if you want this document, you can get it through the cancer support community or through Torrance Memorial. But literally 13 pages of just about any resource you could need for anything help, either psychosocial, financial help, resource lists for standard of care guidelines, et cetera. These are, again, just cancer support community resources through the cancer support helpline, open to options, frankly speaking, about cancer. So now, that being said, I'll open up to any questions and concerns.
Yes, so please feel free to put any questions you have in the chat box, and then I will read them out loud to Dr. Lowe. Let's see what we have going on. So far, I don't see any in there yet. So we might have people.
What's funny about that picture is that nowadays the doctor's supposed to be sitting, not standing. They actually teach that now, as far as the doctor should be sitting when talking with patients. Yeah.
Okay, I think I just saw a question come in here. How long can you stay on immunotherapy?
Yeah, good question. Oftentimes the answer is we don't know. So it depends. So nowadays we do use immunotherapy sometimes in the curative setting. Like my last patient today was a stage 3 kidney cancer, had surgery. He'll be on immunotherapy to try to improve his cure rate for 1 year. Okay, so that's set. So if it's in the curative setting, which is not as common, it's usually 1 year. For the palliative setting, which is much more common, we don't know. Most of the trials, when they were first designed, looked at 2 years of treatment. But the standard is typically, for most cancers, as long as it works for, we usually keep people on it. We can always take breaks whenever. If people want to take a holiday, we take a holiday. But for those who go into remission, that's really the main question. So if someone has a disease you can still see and they still have cancer, well, we just keep on going, and as long as it's under good control. But if someone goes into remission, especially with those immunogenic cancers like metastatic kidney cancer or melanoma, if you had metastatic disease with likelihood of lifelong dealing with that disease until it took your life. Remember I said there are certain cancers where a minority of patients can actually be cured of metastatic disease, especially kidney cancer and melanoma. So if your cancer goes into remission where you can't even see it anymore, then we have a tough time saying, well, do we keep up the treatment because it's working, or do we stop it and test to see whether or not you're cured? So personally, if someone has kidney cancer or melanoma and they go into remission, I usually stop after about 1 or 2 years and then see if it comes back. If it doesn't come back, then they're cured. Okay. If it comes back, then typically I can restart on immunotherapy and I usually see the same benefit. It's usually still very sensitive to the treatment.
Okay, next question here says, does the immunotherapy treatment have any interactions with common vaccines like the ones for COVID or flu?
No, it shouldn't, just the way they work. It's a common question that we're having nowadays, especially with everybody supposed to get their flu vaccine and their COVID vaccine. So my answer to my patients is, if you have cancer, and if you're on immunotherapy, you have an advanced cancer, that's more of a reason to get your vaccines, not less of a reason. Okay. The risk of getting COVID complications or even flu complications is higher in cancer patients and if you're on cancer treatment. So that's more of a reason to get your vaccine.
Okay. I see a question here. Can cancers become resistant to immunotherapy?
Oh, yeah. Yeah. I mean, so the majority of patients, not all patients, but like I said, the majority of patients that we use immunotherapy on, it's for palliative reasons, trying to control the disease, shrink the disease, but unfortunately not to cure the disease. In those diseases where I think that's very important at the very beginning to outline what the goal is. If the goal is palliative, then we know at some point that disease is expected to become resistant to what you're treating, okay, what you're treating with. So for things like, I would say again, breast cancer, my patient, I don't want that to be what's expected, okay? I've never seen that before. I may never see that again. But for breast cancer, when we use immunotherapy, it's usually a pretty modest benefit. And usually within 3 to 6 months, that cancer, even if it responds, will find a way around it, okay? To find different mechanisms to either hide from the immune system or, to not care about the immune system. So I think down the road, the questions will come as far as, well, how did that cancer cell become resistant to the immunotherapy? Right now, we can say someone responded and then they became resistant, but we don't know yet how those cells became resistant to the immunotherapy. In the future, I think we'll be able to do another biopsy and say, okay, this is the mechanism on how it happened. These are the drugs which will now allow it to become sensitized again. So, but unfortunately for the majority of patients, yes, immunotherapy will not continue to work lifelong.
Okay, thank you. Here's a question asking, can you speak a bit more on immunotherapy treatment for advanced colon cancer? I understand that using the therapy for solid tumors is a hurdle at this moment, but are there any immunotherapy treatments for them?
Yeah, so very good question, because colon cancer is one of our most common cancers that we see, but only a minority of colon cancers are treated with immunotherapy. So immunotherapy for colon cancer was first only approved for those with what's called Lynch's syndrome or similar changes to Lynch's syndrome, otherwise known as HNPCC. That's the hereditary syndrome where people are predisposed to colon cancer or intestinal cancers. So that mutation that causes what's called DNA mismatch repair insufficiency, which is similar to like how breast cancer becomes breast cancer for patients with the BRCA mutation. That mutation or syndrome like was only seen in about 3%, not 33% of people with colon cancer. So when immunotherapy was first studied, it only got approved in that small subset of colon cancer. So if everybody we see with colon cancer, if it metastasizes, immunotherapy is only approved in 3%. Now, more recently, again, remember that slide I showed that said that immunotherapy is now approved in any tumor if it has those features. If it has a high mutational burden, okay, if it has microsatellite instability, if it has what's called a high DMMR. Those are the three features, which are still rare to see, but that has allowed me to treat some colon cancer patients beyond that 3% with immunotherapy. Okay. But unfortunately, we have not yet, for the majority of people with colon cancer, we have not yet found the right immunotherapy for the majority.
Okay, here's a similar question. Can immunotherapy be used for pancreatic cancer?
Yeah, the answer for the standard of care, no, unless it has, again, the mismatch repair deficiencies, the DMMR, or the high mutational burden. And again, that's a very small subset of pancreatic cancer. So only a small subset, probably again, only about 3% of pancreatic cancer, unless someone is on a clinical trial. So a lot of the clinical trials we have nowadays are using immunotherapies in different ways than we've tried before.
Okay, this one sounds like a more general question. Should we have the COVID vaccine and the flu separated, say, a month apart?
Yeah, so that also comes up almost every day in my clinic. So I'll just tell you what I did. I separated it by a week just because I didn't want to deal with more fever with the two. Now I did fine with both of them. I didn't have any side effects. My wife got it both the same time and she was fine. The CDC has actually recommended just to go ahead and get both at the same time. Now, the reason for that is because the flu season is going to be a very bad flu season. We're seeing the flu pop up now a month before we usually see the flu. I mean, half my kids' school is out with the flu right now. So it's ridiculous how bad the flu season is already starting. And of course, we know how infectious COVID has been. So the impetus for the CDC to recommend that was just to get your vaccine as soon as possible, because it usually takes at least 7 to 10 days for your immune system to really start to amp up after a vaccine. So if you get a vaccine and you're exposed to the flu 3 days later, the vaccine probably didn't do anything for you. You need it in early enough, probably at least 7 to 10 days to really help. And then, the flu, people have often said, well, the flu vaccine doesn't work. That's not true. So depending on the year, the flu vaccine is sometimes great. It completely prevents the flu for the majority of people. More commonly, it doesn't prevent the flu. It keeps the flu from getting bad, right? Every year for decades now, the flu kills anywhere from 10 to 30,000 Americans a year. It's always been like that. And yet, I don't think it got much attention until maybe COVID came out. So maybe one of the best things about COVID is people are now reassessing and realizing again how important the flu vaccines are. Okay. So remember when we said that the COVID was the worst virus to ever come out since the flu pandemic, okay, 100 years ago. So the Spanish flu 100 years ago, I think it infected 1 out of every 3 people, and 10% of those people infected died. Okay. So literally it killed 3% of the population. So imagine a 1 out of 3 chance of getting the flu and 10% died. Okay. Thankfully, we haven't had that degree of a flu in 100 years, but the COVID pandemic has reminded us that any of these viruses can come out at any point. So yeah, no question. I always get the flu vaccine every year.
Great. Okay. Thanks for that. Next question says, I had colon cancer that metastasized to my lung. I am in remission now, but I am in treatment for breast cancer now. Would immunotherapy be useful if either one returns?
Yeah, that's tough. I mean, congrats on being in remission for the colon cancer. Just for one point, for colon cancer, it is an interesting cancer where even if it spreads, if it's limited spread, we do remain aggressive about surgery or radiation because we can sometimes cure patients with stage 4 colon or rectal cancer. Okay. So if either of those two diseases grew, came back, it again depends on the circumstances. So for colon cancer, we would need a biopsy to test for those specific things I mentioned as far as the minority of people with colon cancer can get immunotherapy. For breast cancer, immunotherapy now is only approved in certain situations. It's typically for triple negative breast cancer, and only if the target for immunotherapy, the PD-L1, is usually has to be at least 10% on the surface of those cells. Okay. So again, in those situations, it's just a minority of patients. So again, we wouldn't know unless you actually did a biopsy of the tumor.
Okay, great. Thanks for that answer. This one is asking about immunotherapy being effective in the treatment of esophageal cancer.
Yeah, we do use immunotherapy as standard of care. Now it depends. So in esophageal, like first line in the curative setting, within the last year, remember I said the majority of immunotherapies are used in the palliative setting. Well, last year for esophageal cancer, if you were treated for like stage 1, 2, or 3 disease, we often give chemotherapy and radiation first and then do surgery. If you get chemoradiation and you have surgery, which is a big surgery, and you still had cancer cells in the specimen, if it didn't all go away and there's actually was still cancer in that specimen, the standard of care is to consider giving immunotherapy after surgery. This just changed recently in order to try to improve cure rates. Okay, so that's now standard of care. In the metastatic setting, the standard of care is chemotherapy with possible use of immunotherapy. It usually requires the PD-L1 on the tumor, the marker for the target of immunotherapy, to be 5%. And if it's 5%, then you can use immunotherapy. Otherwise, no. Now, second line and beyond, we used to use more immunotherapy for esophageal. It used to be a blanket, you can use immunotherapy in second line. The FDA actually withdrew that indication because of further studies showing lack of benefit. So they're still doing studies with it, but it's really for a subset now for the PD-L1 positive group.
Okay. I see 2 questions here that are similar, so I'll ask them together. One is, can Keytruda or radiation cause cancer to return in the original site? And the second similar question says, can immunotherapy make cancer worse or speed up tumor growth?
It shouldn't, because immunotherapy, like the checkpoint inhibitors, they don't directly do anything to the cancer cell except for getting rid of that bad system, either on the cancer cell or the T cell. And that bad system is just a way to try to get past the immune cells, right? So it shouldn't, just the way they work, it shouldn't have any ability to cause those cells to grow faster. Now, there's a separate issue where it doesn't make it get worse, but it can look worse on the first or second scan after someone starts immunotherapy. It's not uncommon that we see what's called pseudo progression. Pseudo meaning fake progression. Okay. What I mean by that is someone like with lung cancer gets put on immunotherapy. They start feeling better. If their tumor marker is high, it's coming down. There's good evidence clinically they're feeling better, getting better. We know it's getting better. And yet you get a scan and everything looks worse. And the reason for that is not uncommonly pseudo progression. If you imagine how these treatments work, if they work, the immune cells will start to recognize cancer as being cancer, and the immune cells start to flood into the cancer itself. That starts a battle, right? The immune cells start to attack the cancer. I had a patient today with Hodgkin's disease in his left neck. He said the day after he started the immunotherapy, it all became warm and hot. And then this was just a week ago. And he said every day since, it's gotten smaller and smaller and smaller. Okay. So what happens is those immune cells flood into it, and it can take time for those immune cells to start to settle down. So on that first CT scan, sometimes we see fake progression. It looks worse, but that's not actually worse. It's actually the immune cells doing what they're supposed to do.
Okay. I know we're a little bit over time. Do you have a chance for maybe 1 or 2 more questions here?
Yeah. Mm-hmm.
Okay. So this question is asking, how does diet affect someone on immunotherapy?
So diet we do not recommend any change in diet for immunotherapy. Unlike chemotherapy, where if it affects your white blood cells and we worry about low white blood cells, and people have to be careful about bacteria in their diet. Immunotherapy typically doesn't affect that at all. Okay, so people can eat a normal diet. Now, for the more common question I get is, well, what about diet treating cancer? Is there something I can do to eat or drink or stay away from to treat cancer? The best data for diet and cancer is for prevention of cancer, right? Like the Mediterranean diet is probably the best diet, high in fruits and vegetables. If you eat meat, it's kind of fish and chicken, low in red meat. That's probably the best diet, not just for cancer, but just in general for overall health, heart health. But if you eat the perfect diet, the idea is to not have too many toxins in the food, right? If you eat a bunch of greasy, nasty food and a lot of barbecued food, red meat, which we know can mildly increase the risk of certain cancers. We know that all cancers are due to mutations, genetic mutations. That's not inherited mutations, but mutations that develop in the cancer cells. So eating a bad diet, smoking, not taking care of yourself can increase the amount of mutations that those cancers develop. Most mutations, though, that happen in cancer cells happen by chance. Every cell in your body has to divide, right? In order to stay alive. When you divide, you're dividing and replicating the DNA. Every cancer becomes cancer because of mutations of the DNA. And instead of saying, okay, you're a skin cell, you're supposed to stay in that place, you're not supposed to divide and invade into the surrounding tissue or spread, the instruction booklet is supposed to have a bunch of do nots. Do not do that, do not do that, do not do that. Usually by chance, but if you don't take care of yourself, you'll have more random mutations. But if you get a mutation that does, instead of saying do not, it says do those things. Do invade if you want to invade. Do spread if you want to spread. Do grow in the liver, even though you're not a liver cell. That's what causes cancer. So it's usually a number of mutations that have developed. What I tell my patients who have metastatic cancer is I think food is one of God's great gifts. If you have limited time on this earth, enjoy your food. Okay. I do not think there is anything in particular someone can do for most cancers to eat or drink or not eat or drink that's going to change your cancer once you've had cancer. Now, if someone wants to practice a good diet, that's great, like the Mediterranean diet. But what I worry about is people who don't get enough calories or don't get enough protein, and then they get too skinny, too thin, and they can't put up with the treatment or they put up with the insults of their disease. So I think it's most important if you have metastatic or aggressive cancer that you maintain your calories in order to maintain yourself.
Wonderful. Well, thank you so much, Dr. Lowe. I think I'm going to wrap up the questions there only because you've gone almost a half an hour over the program time, and we're so appreciative of your time.